That's great, got it. Well, good morning, and I'm delighted to be here today and very honored to be part of this PCORI conference, and look forward to hopefully having a chance to talk with some of you and learn from all of you. So I direct the Perinatal Psychiatry Program at UNC, and wanted to spend some time talking about perinatal mood disorders, which are one of the most common and often unrecognized complications of the perinatal period, with devastating consequences for patients and their families. We know that perinatal mood and anxiety disorders during pregnancy are associated with worse birth outcomes, including lower weight gain, increased risk of preterm birth. All of this can translate into difficulties with attachment between mom and baby, and it is one of the greatest causes of maternal suicide in the postpartum period. In most severe circumstances, it's also associated with infanticide, so these are obviously devastating things for families. And unfortunately, there's been very inconsistent use of practice guidelines, routine screening. The symptoms can look different from classic DSM depression. By DSM, I mean Diagnostic and Statistical Manual. So for a lot of women, it presents with a lot of anxiety, ruminating thoughts, activation, not necessarily just being sad and blue. And that can be confusing to both people suffering with it as well as for providers. And it also, there's not one size fits all. The way this presents can be very different for individuals, and we have to have a better way of making this part of routine fourth trimester care, and that's something that Allison Stubbe and I have been collaborating on for almost a decade, or maybe it is our 10-year anniversary. So more recently, the media has gotten interested in this as a topic. This was 2 years ago in the New York Times, Climbing Out of the Darkness of Maternal Mental Illness. And one of the things we do know is we can diagnose it and we can treat it. And in general, if you can diagnose something and you can treat it, it would be really great to get that word out to everyone. But what happens in this country is that screening is extremely spotty. There are places that do a brilliant job at it and other places 10 minutes away that do absolutely nothing, leaving any individual woman to maybe or maybe not get care. And then even if they are screened, oftentimes there's complete insufficiency of services available, so you might be told you have this and have no one to help take care of you. And all of this is just completely unacceptable. So in late January, the U.S. Services Preventative Task Force came out with recommendations for routine screening of all pregnant and postpartum women for depression. And this is huge because this governing body helps to strongly influence both legislation and how insurance companies cover things. It also often makes a big difference in practice patterns. And I think many of us are very hopeful that this will lead to real changes so that it's no longer an optional kind of thing that if you get around to it, it would be really nice if you asked your patients, but it's seen more as a mandate and something that can't be ignored as is with all other health issues. So we don't ignore cardiac issues, we don't ignore blood pressure issues, and we can't afford to ignore mental health issues. So one thing I wanted to transmit today was to discuss some of the distinguishing characteristics or symptoms. So anxiety is often a hallmark sign, and even though anxiety is unfortunately not listed in the depressive symptoms, it often occurs for many people with depression, but particularly in women and particularly during the perinatal period. You can feel depressed, you can feel blue. Some people may feel very irritable, feel like everything's getting on their nerves. People can sometimes have a lack of interest in a newborn, or alternatively feel overly consumed and worried about the baby, can't put the baby down for a minute. Will have really intrusive obsessive thoughts about what happens if I'm cooking in the kitchen and a knife hits the baby, in ways that prevent the mom from enjoying the baby. It all becomes just a very fear-based, consuming kind of thing that's really, really awful for all involved. And for many women, they'll report feeling the most dependent they've ever felt in their lives, for very good reasons in many ways, but that can be a very uncomfortable symptom. So what is it about the postpartum period in particular that initially attracted so much attention? This comes from Danish registered data, which is able to track entire populations. This was a JAMA article in 2006 that showed this spike in symptoms. So we do know that from a prevalence point of view, the first 4 weeks postpartum are one of the greatest risk time in a woman's life for onset of depressive symptoms. And this is a complicated interplay of all the hormonal changes that go on. that may trigger mood symptoms in women who are genetically vulnerable. We know that a combination of psychosocial factors, early adverse life events, all of this may interact with the way the changing level of hormones interacts with your genes to make 10 to 15% of women very vulnerable for clinically significant symptoms. But there's so much we don't know yet, and there's many research questions. And so when I have on this slide exploring the phenotypic heterogeneity, to make that a more accessible term. So phenotyping just means clinical diagnosis, and that's to distinguish it from genotype or studying someone's genes. And anything that's heterogeneous is just very mixed. And so we want to understand what are the different factors when we think about depression and anxiety during pregnancy or postpartum. Are these different groups of people? What's the underlying biologic cause? Why do some women become suicidal? Why do some women become floridly psychotic? Why do some women have mild symptoms? Why do some women then go on to develop lifelong psychiatric illness? Why do some women only have it at this time? We don't know the answers to that. Does it make a difference if your symptoms happen in the first trimester, in the second trimester, in the third trimester, in the fourth trimester? For some women, they're diagnosed postpartum, but they may have been depressed for 20 years, and no one ever asked them about it. And certainly adding a new baby to the mix didn't make their depression go away. In fact, now you're just exhausted and sleep deprived. So we know that prior history of anxiety, of depression, and of other psychiatric issues increases your risk. What about the role of pregnancy complications? Should we see any woman who's diagnosed with gestational diabetes as being high risk? Should we change the way we provide care to target specifically those with complications, including obviously people that have had traumatic birth experiences, preterm birth, babies in NICUs? And how do we think about the changing levels of female reproductive hormones? So in all women during pregnancy, depression, with or without depression, progesterone and estrogen go sky high and then plummet postpartum. And lastly, how do we think about the genes and the interaction with the environment? So I was able to work with a group in Sweden, and we were able to show that actually perinatal depression is more heritable, meaning you pass it along in families than depression outside the perinatal period, giving more credence to the fact that there's more of a genetic influence. And as we think about how we take care of people, we need to think about how do we target people in outpatient clinic settings who are receiving obstetrical care. Our UNC Center for Women's Mood Disorders has well over 3,000 visits a year. How do we offer inpatient specialized treatment for those who are most severely ill? We have one of the only mother-baby units in the country, and people come from all over, and that's grossly inadequate for a country of this size. And then how do we have appropriate community treatment, education, and support? So one of the things that Dr. Stubbe and I have spent a lot of time thinking about is how do we integrate routine screening into obstetrical settings? What current models currently exist? How can we make this something that's everywhere, especially with the new U.S. Services Preventative Task Force recommendations? So there's some really interesting work out there on telephone-based support using nurses, some using peers, some integrating mental health care directly in OB clinics versus having to refer out. And we obviously need legislative support for all of this. So I'm going to get to the conclusions before the music plays and Sarah throws me off the stage. But one last thing, we launched on Monday, our group launched an iPhone app that is doing clinical diagnosis and being able to collect DNA samples for anyone who's ever had a lifetime history, current or lifetime of postpartum depression. And I was late getting over here because I was stuck in something with that, but it's getting just enormous responses across the country. And so it's called PPD Acts. I couldn't include it in the slides because Apple would have killed us if we had anything released before Monday. But if you are able to spread word and tell anyone about it in whatever ways you're able to, that would be fantastic. We want to get 100,000 people worldwide, and this is happening in multiple countries. So lastly, perinatal depression and anxiety affects conservatively at least 1 in 8 women. It's one of the greatest causes of maternal mortality. And screening and treatment absolutely are associated with improved outcomes for both the mom, the baby, and their family. We have to work together to understand how we overcome barriers to routine screening so we can implement treatment And understanding the biology and the genetic signature will allow us to identify who's at risk early, be able to do prospective screening, and ultimately have novel treatments that really help moms and their families. Thanks.